All right, I want to welcome everyone in our global radiology community from different parts of the world to the Health for the World COVID-19 Global Radiology Panel. We have radiologists from 80 countries who stand united more than any other times to fight the pandemic together. As we fight this pandemic together and focus on reopening, there are important lessons which we can learn from each other. Health for the World is a nonprofit initiative which we created 4 years ago in honor of my grandfather. The co-founders are me, Dr. Bill Dillon, who's the Executive Vice Chair of Radiology, who is here right now, and Dr. Ankur Parija, who is a physician at Stanford University. My grandfather and my parents taught me the principle of seva. They used to say, do selfless good for others without expecting anything in return. I can still hear those words. My grandfather lived in a small village in India, and years later, Health for the World is helping doctors and patients in low-resource communities in 80 countries. During this journey, we have been really touched by the goodness on earth, as this is a completely volunteer-driven global movement. I know many of you will be listening to this webinar in the recorded version. No matter how you're listening to this webinar, I would like to extend a warm welcome. I want to welcome Dr. Bill Dillon, who's a co-founder of Health for the World and Executive Vice Chair of Radiology at UCSF, and has helped shape Health for the World initiative. Next, I want to welcome our excellent panelists today, which is very exciting because we have radiology leaders from different parts of the world for this panel today. The format is simple. Our 5 panelists will present their department and experience of preparedness and reopening about COVID-19. This will go on for next 35 to 40 minutes. Then we have questions which can be answered. You can submit your question using the Q&A box at the bottom of Zoom, and we'll try to answer the questions during the webinar. If the questions are unanswered, we will also reply to your emails and answer the questions later. I would like to welcome our first panelist. Our first panelist is Dr. Max Rosen. Dr. Max Rosen is the professor and chair at the Department of Radiology at University of Massachusetts Medical School. Dr. Rosen will be talking about his experience with preparedness and reopening at University of Massachusetts Medical School. Dr. Max Rosen, you can share your slide when you're ready.
Okay, let's sure this share. Wonderful. Can everybody see my first slide?
Yes.
Great. Okay. Thank you, Dr. Rahani, and all the other panelists, and it's a pleasure to participate. For those of you who don't know, University of Massachusetts Med School is in Worcester, Massachusetts. It's about 45 minutes due east of Boston. So we are considered the central part of Massachusetts. And sorry, okay. And so this is the data of the impact of COVID in central Massachusetts. We're the major level 1 tertiary medical center for the area. It's about 1 million people in our catchment area. And this graph starts at the end of March, on March 24th, and goes through last week, through June 14th. And the green line at top is the number of COVID-positive inpatients in central Massachusetts. And most of these were at our hospital. And you can see it's really almost a perfect bell-shaped curve, peaking on May 1st, and now at about 340 patients. And now we're down to about 50 or 60 inpatients. This dark blue line are the number of deaths from COVID, which keeps increasing and then now is fortunately leveling off. And then the light blue line here is the number of patients on ventilators. And you can see it's also a bell-shaped curve, and parallels the number of inpatients, but fortunately much flatter. When we were at our peak around May 1st, we were at about 130% of our ICU capacity. But fortunately, because we had about 4 or 5 weeks of lead up, we were able to create additional ICU beds and ventilator beds so that we never had more patients than what our capacity could handle, even though with normal operations, we would have been 30% over. This next slide is a snapshot of the impact of COVID on our radiology volume. And our baseline week that we compared to was the last full week of January. And then week 1 of COVID, we take to be the week of March 19th to 25th. And this data goes through June 10th. And I picked 2 modalities, which are, the larger modalities for our productivity driver. And so this graph shows our MR volume. On an average week, we do about 800, 820 MRIs. And then on the first week of COVID, the volume just plummeted down to around 400. By week 6, which was the last week of April, we were down to 230, and then there's been a slow increase back up. And last week we were at about 3/4 of our outpatient MRI capacity. The red and the blue are inpatient MRs, and they've maintained fairly stable, but the numbers are relatively low. The next graph shows the impact on CT, and the blue is CT in the emergency department. And we did about 950 studies a week before COVID, and then it precipitously drops down to about 500, and then slowly we start to go back up to our normal. And the volume in CT paralleled the number of visits to the ED, which I think initially patients were staying home, even though they might have had serious conditions because they were afraid of coming into the ED, and then gradually, as things reopened, became more comfortable coming back into the hospital. The number of inpatients dropped. We on purpose, stopped all elective surgeries, and so in all non-necessary admissions. I think the decrease in CT reflected that. And then outpatient also plummeted down from about 700 a week to about 150, and we kept this very low. We had pretty much closed down our outpatient imaging, and then that's now slowly starting to return. I've tried to think about what our experience with COVID has been in radiology, and thought that it might be good to think about this in 4 phases, with phase 1 being the crash. Phase 2, I'm calling the scramble, when we're trying to figure out what to do. Phase 3, the recovery, which hopefully has been more thoughtful and planned. And then 4, trying to figure out what the future is going to look like. So the crash. So during the crash, we immediately stopped all our outpatient imaging studies. The hospital canceled all elective surgeries and left inpatient beds empty to be able to handle increased COVID patients. Patients themselves were avoiding coming into the ER, especially even for acute things like MIs and strokes, things that you wouldn't expect that people would be able to wait for. There was also a lot of fear amongst the frontline providers within radiology, the ultrasound techs, the interventional radiology teams, about being exposed to COVID. And we sent probably 3/4 of the radiologists home because there was really no work for them to do, and we wanted to decant the reading rooms. Phase 2, which I'm calling the scramble, and for those runners, this is the start of the Boston Marathon, which did not happen this year, which would have been in April. So in phase 2, some of the issues we were dealing with was, what's an appropriate imaging strategy for patients with COVID? Do we do X-ray? Do we do CT? We set up an outpatient tents and put digital radiography in the tent so that patients could have their X-ray imaging without coming into the hospital. We thought about bringing in a mobile CT scanner, but decided against that. I know some places in the US did rent a mobile CT, so all the suspected COVID patients could be imaged in the trailer outside of the hospital. We also spent a lot of time working on processes for decontaminating imaging equipment after exposure to a COVID positive patient. There was a lot of uncertainty around the appropriate use of PPE for radiology providers. And we had about 3 or 4 different policies that evolved over time. And because it was a moving target, it caused a fair amount of uncertainty and some anxiety among the radiology providers. We also lost some of our radiology space. We had about a 15-bed radiology recovery area, which became inpatient space to take care of our increased number of inpatients. And then we had to scramble to find places to recover patients who were having IR procedures. We also decongested the reading rooms. We moved some PAC stations to people's offices, and we also spread out the PAC systems in the existing space. We, at the end of April, we purchased about 20 more home PAC stations, which we're slowly deploying so that radiologists could work from home. By the time we deploy these, it'll be the end of July. So hopefully it'll be after COVID, but I think it'll leave us in a good position in case there is another surge that people could be doing more work from home. During the scramble, we also sent all our residents home and didn't have them working, and we stopped teaching conferences. During the recovery phase, which has really been the past month, we've been working to prioritize patients to come back for semi-elective imaging. We've been focusing on patients who need oncology follow-up, on bringing back patients who need screening mammography or lung cancer screening, and then other semi-elective procedures. We've also been trying to identify what the appropriate use of PPE is for our radiology staff. In an ideal world, if the PPE was unlimited, we would just have everybody wear full PPE for every encounter, but that's just not possible given the limited supply. And then for our faculty, we've been struggling with how to account for what we're calling COVID time. Should we allocate this to vacation, academic time, or just say it was due to COVID and we gave people the time off and we're not going to count it against any other time? And also struggling on how to equalize the time off between different divisions. For example, in mammography, when we stopped all screening mammography, there was really no work for the breast images for several months, but our ED radiology group and our IR group were working full time. And we're looking to try to make that fair and equitable for the different divisions. And then for the support staff, many staff have been reluctant to return to work and want to continue to work from home. So I've been working with our human resources department, our HR department, to try to figure out how to bring people back into the offices and have them feel safe. And then the next is the future, which is really unknown. And from the technical side, we're trying to figure out whether we need imaging equipment just dedicated to imaging COVID patients. How are we going to effectively have social distancing in the waiting rooms? Normally our waiting rooms can have 10, 20 people, sitting pretty close together waiting for their exams, and that's just not acceptable anymore or possible. We're also looking at extending our hours of operation for CT, MRI, and ultrasound, so that would allow to have the same number of patients move through the department in a day, but have increased time in between patients for cleaning. For the radiologists, we're still figuring out how to decant the reading rooms and what the correct number of radiologists in each reading room should be. We're also working on policies on who's going to be able to work from home and when they're going to be able to work from home. And we're also thinking about what our long-term staffing needs are. If we're susceptible to these major plunges in radiology volume, do we continue to hire and maintain a staff for 100% of volume, or do we try to maintain our staff at a little bit lower level? On the financial side, at the medical group level, which is a multi-specialty group level for all the departments in the hospital, we're having discussions about whether or not we need to keep specific reserves in place in case there's another pandemic. And in the past, we really haven't had reserves for that purpose. And then for the residents and fellows, we're trying to figure out the best way to continue their education and whether we can effectively teach them remotely. What we're finding is the first and second year residents are very uncomfortable with remote readouts or teaching, but the third and fourth year residents might actually prefer it, and they find they can get through more cases in a shorter period of time. And then the last thing is, what's the impact of COVID on the department participating in national meetings and CME? Aside from the educational component, there's a lot of networking and career development that happens at these meetings, particularly for younger faculty. And we're working on ways to try to understand how we can provide that opportunity for our faculty, even if things are remote and on Zoom. So hopefully I stayed within my 7 minutes, and it's sort of a whirlwind view of some of the issues that we've dealt with, and I think the issues that we have to deal with, going out into the future. So thank you.
Thank you so much, Dr. Rosen, for the excellent presentation. And I really like how you divide it into 4 phases very systematically, and also giving an idea about the future challenges which are going to come up for all the radiologists. So thank you so much. We really appreciate this. And it was an excellent talk. All right, our next panelist today is Dr. Guillermo Elizondo. Dr. Elizondo is the chair of Department of Radiology at the Hospital Universitario at UNL Monterrey in Mexico. Dr. Elizondo, welcome, and you can start whenever you are ready.
Hi, thank you, Dr. Hani, Dr. Dillon, for the opportunity to speak in this excellent webinar around the world. And as Dr. Hani asked me, I'm going to focus more on the teaching part of how we reopen our department, how we are dealing with the reality right now. We start in Mexico in March, the first case. But then in June, the authorities, and basically because of the economic and financial things, we have to, let's say, go to normality. But I have to tell you that these are data from yesterday. Yesterday was, June 21. You can see on the left, and is where you can see the curve here. I mean, we have a very steep curve. We are not in a plateau. We are in the pandemic, and as a matter of fact, we are increasing compared even with the United States. We are compared with the number of deaths per capita. We are, right here, increasing. As a matter of fact, yesterday was the worst day in history. I mean, in Mexico, more than 1,000 people there. Yesterday was the worst even in the world. And this is very important too, because in this graph, you can see that more of 50% of people that is tested is positive. This never happened even in the worst days in New York or in Madrid. So we are living with that. But anyway, we have to continue. We have to reopen. And in particular, I'm going to focus, as I said, on the teaching part in our radiology department with our residents. And what we did, after all this scramble and crash that Dr. Rosen perfectly described, is that, well, we have to reopen and we have to restructure our academic program. So what we did, and probably everybody is doing that, is that we divide our residents and teachers into groups, alternating, by 2 weeks, one at home, one at the radiology department, and every radiology station has at home and at the radiology department residents, members, teachers, and fellows. And we're doing all this through Microsoft Teams, which is the platform that we have in the university. So every resident tried to accommodate at home the iPad, the laptops or screens or televisions that they have the same way that professors did, in order to have this way to collaborate. I mean, basically we are doing virtually what we were doing before in our radiology stations. As a matter of fact, if you see, these are the radiology, excuse me, the stations that we have on Teams. So every single station has Teams members. Excuse me. This is the way they review the cases on the workstations. They actually do the reports, and you can see how many of the residents and professors are in every single session, and you can ask them and contribute to participate. Actually, Teams allows you to take the control. You can show with an arrow where the abnormality is. You can describe everything, and you can contribute and collaborate as if you were face-to-face in the workstation. We also continue now with our sessions, either intra-departmental and interdepartmental. We have now tumor boards and the academic sessions that we used to have everything through technology, through virtual cases. This is something very important I want to share with you because this was built by the input of the residents, all of them, the chief residents and the professors. Because at the beginning, I mean, when we have to lock down and crash in March, well, we divided in two groups, and then people who were at home, well, they have the, I will say, the obligation to go to the morning session virtually, but the rest of the day was like a floppy day. So after that, they said that we have to have more structured program, and this is what we have now. And this is a self-assessment for each resident for the 2 weeks he or she is at home. They have obviously to go through all this, which is a self-assessment thing, as I told you, and obviously it's more than 8 hours there, but one day, I mean, all days they have to go to the morning session, but depending on what the research of the review of cases, going to the RAD premiere, if they have to answer things for their own study. And we'll even include a healthy hour because, I mean, you remember before this pandemic, the epidemic in radiology and in medical specialties was the burnout. So we think that this is a very important to have a space for you in which in an obligated way you have to meditate, to do yoga, or just relax during your working day. So every single resident receives by planner what he has or she has to do on all the week, every day. And she has all the schedule and how it's advancing. So we continue our daily morning sessions. We have in our auditorium the people who is at the hospital. They are there with social distancing, so physical distancing. We continue all our classes or sessions that you can. I encourage you to see them in our page. There are more than 400 of them. Every single day we have classes, we have teaching sessions that we all broadcast live, so you can go there. We also contribute, like in this moment, with webinars and participate actively in that. With the ground rounds, every radiology professor has a ground round every single day, so residents, both at the hospital, at home, they participate in that. The evaluation, this is a very important thing because we used to have this written form of evaluate the residents. Now we digitize that, and this has to be filled by professors. The evaluation now is taken by 2 professors by the residents in every single workstation. And you can review what they are answering, I will say, and you provide them with immediate feedback about what is happening. We continue participating with our residents in national and international seminars, like in this one I am doing them right now, but all my teachers, all my residents are working very hard, even with the medical students too. We are more active, obviously, on social media. You have them. I will put this at the end of the presentation too. And through social media, we are publicizing now our research papers, teaching cases. Every week we have several teaching cases on the web. And something very important that I think we are doing is contribute to educate the community about what we have to, not radiology, but everything that we have to do just to confront this pandemic thing. So to conclude, I think the resident training can and should continue during the pandemic. And this is something very important and we are doing right now. The competence acquisition and the evaluation is possible, and we are doing that. We are improving every day, basically also because of the feedback of residents and professors. This is something that we are improving. I think the participation of radiologists is fundamental in patient healthcare, and this is, I mean, now we have the opportunity to show that more and more. I am an advocate of being a visible radiologist, and I think this moment is a very particular one in which we have to continue our consultations to patients. We have that in our department. The interdepartmental sessions and all this collaboration with the rest of our colleagues. I think this is very important. We we have this opportunity. And this is a challenge, as I told you. We are in the ascending part of the curve. I don't know if this is the peak or not. I think this is going to be worse. But anyway, this is for me and for all our department. We think this is an opportunity to develop new abilities and competences for the future. But also, we have the opportunity to show the radiologists, we have the technology, we can leader, we can be the leaderships in, in this new part of new area of information technology, telemedicine, and teleradiology, and virtual interaction. And with that, I would like just to finish. These are our social media and personal ones, and thank you very much for your attention.
Dr. Lisandro, that was very impressive. It is very impressive how you have continued the mission of education during these challenging times using virtual tools. And I completely agree with you. We are radiologists and we have the best technologies, and we can certainly utilize them for education at this time. This was a very, very impressive. Thank you so much. And please keep safe, you know, what you told me about yesterday and the Mexico cases, you know, so it seems to be a very challenging time.
Thank you very much.
As compared to what we talked, you know, 2 months back. So I hope everybody keeps safe. All right, so our next panelist is Dr. Cleenam Zefi-Teti. Dr. Cleenam is the head of radiology at Kolebu Teaching Hospital in Ghana, Africa. Dr. Teti, you can start whenever you are ready. And for everyone who has joined the session, please feel free to enter the questions and answers in the Q&A box. We'll try to address them during the talk or at the end of the talk. So Dr. Cleenam, I don't think we can see your slides. It just says Dr. Cleenam has started screen sharing. Yeah, now we can see them. Very good. Yes.
Yeah. Good afternoon. Thank you, Dr. Rahina, for having me. This is just an image of the Kolebu Teaching Hospital. It's the administration block. Ghana's situation about COVID-19. On the 12th of March, we confirmed 2 cases, and these people returned from Norway and Turkey. So we refer to them as imported cases. As of today, we have about 14,154 confirmed cases and unfortunately 85 deaths. What we do in radiology is that confirmed or suspected cases are transported to the department for chest CT or chest x-rays. Because we are having difficulty in the delays of releasing of the PCR tests. So the doctors want to know whether the patients have any features of COVID-19. So we usually do the chest CT and then chest x-rays for them. The radiology department has many entrances, about 4. So we have blocked 2 entrances and just kept 2 to be able to screen cases. We also form a dedicated COVID-19 team, which is made up of the head of radiology department, which is me, 2 radiologists, 3 trainee residents, 4 radiographers, nurses, liaison officers between the other departments and the radiology department. Then a storekeeper who keeps the PPEs. Then we have 3 infection control officers, an orderly or cleaner, and then 2 security men who enforce some level of security. So this is just the COVID-19 team. And because the virus is so contagious, most people are afraid to handle COVID-19 people. So before we start a procedure on them, we say a short prayer which enhances us, though we don't full PPEs. Then an ambulance comes close to the department, and then an infection control officer sprays around it to decontaminate. The ambulance is open, the patient is sent in, and as the patient is even sent in, the infection control officer decontaminates along the way. After the procedure, we decontaminate the equipment, and then the patient is sent back. Some general measures have been taken when this COVID-19 arrived in Ghana. As I said earlier, we have now 2 dedicated entrances where we do thorough screening of staff, patients, and their relatives. Every staff, you can see that the nurse there is taking the temperature of that patient who is about to enter. We take the temperature, we screen, asking other questions. Then we also observe strict hand hygiene. You wash your hands with running water. Because we don't have sinks around, but just inside, we have installed these things we call Veronica buckets, and then these sinks here. So everybody washes their hands with running water and soap, and then hand sanitizers are applied and before you enter. And also we enforce that everybody wears masks, the staff, the patients, and their relatives. In fact, in Ghana now, it is now a law. If you do not wear face masks, you'll be arrested. So in the department, we have put signages all over the place. No face masks, no entry. And we've also reduced the number of patients that follow or accompany the number of relatives that accompany their patients. We've reduced them to 1 so that we can observe social distancing in the waiting areas. Now, imaging of our patients, we have now reduced a lot of imaging. We now have respond to non-emergencies were now postponed. Screening mammography has been postponed for some time now, and all the patients that we image have to wear face masks. And we now have 2 dedicated imaging rooms for suspected and confirmed COVID-19 patients. And also, the wards that are closer to the department, some patients come in a wheelchair or on a stretcher. Even as they are coming, we have infection control officers following and decontaminating the pathways that they are following. And when they finish the procedure too, the same thing goes on. So you can see an infection control officer behind a nurse who is wheeling a wheelchair, decontaminating the pathway. After that, we decontaminate the equipment as well, because we don't have many equipment. So sometimes it's the same equipment that is used for some of the cases. In terms of staff, we have to protect the staff. So we provide them with PPEs. Everybody wears face masks, face shields, and gowns and gloves, and sometimes even boots. The staff were trained to don and doff the PPEs because we realized that it's when they are removing the PPEs that the infections take place very often. So they were trained, we were trained how to wear it and then how to remove it. You can see that there's staff, we are now wearing the PPE, and the one they're wearing PPE to assist in the procedure. We also drew flexible duty roster for the staff so that we reduce the number of staff at the hospital at the time. And this has all helped. In terms of teaching and meetings, all the meetings are held by Zoom. So we use Zoom meetings. Even this morning we had one. And the residents who are supposed to stay at home, but they learn through the Zoom or the webinars that we hold every morning. We also give psychological support because unfortunately, the Ghanaian community, though our deaths are not too high, they've seen a lot on TV. So most people are afraid even to come to hospital or even to come to work. So we offer psychological support to the staff, to the residents, and even to the patients and their relatives. When this disease started, COVID-19, we all thought that it will remain in China or Europe, but diseases do not know borders. So COVID-19 has come to Ghana and the cases are still rising gradually. There is now community spread. And also because of that, patients are afraid to come to hospital. So we have to learn to manage the COVID-19 patients and also concentrate on the other patients that have chronic diseases like hypertension, diabetes, CVAs, and others. Because COVID-19 is with us, how do we recover? We have to psych ourselves that the disease is going to live with us for some time now. So as much as possible, we are trying to purchase more portable equipment like ultrasound machines, mobile x-rays, and have a dedicated CT scan machine. We also have dedicated imaging rooms. We are getting 2 so that we can having the suspected and confirmed cases done over there. We are having problem with the results. So we always, a suspected case, we also take as a COVID patient because the results take some time before we get them. And we also plan to train the radiographers so that they can identify the basic imaging features of COVID-19 when they are imaging patients and then reports. We also have to prepare for other emergencies like trauma because at the moment, every attention is on COVID, and we should know that other cases like trauma and the chronic diseases are also available and coming. One problem is with PPEs. So we were able to make available PPEs like N95 masks, face shields, and scrubs for every staff. And then we are planning to have a dedicated COVID-19 waiting area so that when they come, they can have a place to wait before their procedure is done for them. In Ghana, in my hospital, we are digitalizing portions of the hospital. It's not yet complete. Soon, the whole hospital will be digitalized, but we still handle request forms. So for that matter, we're planning that request forms should be placed in polythene bags to reduce the cross-infection for those staff who are going to handle it. We also want to encourage patients to come for imaging because most of them are afraid to come to hospital. And though they are sick, they don't want to seek medical help because they think when they come to hospital, they will catch the infection. And another problem which we are facing in Ghana is the stigma, which is associated with those who tested positive for COVID-19. So we're trying to encourage people to remove that stigma. People who have come on TV to talk about their experience with COVID-19 are being stigmatized, and even at work, at social gatherings, and everywhere. So we have to remove that stigma before things will be all right in this country. Thank you so much for the opportunity.
Thank you so much, Professor Greenham, for this very impressive talk. And it's very impressive how you have kept your staff and faculty safe during this time with all the safety measures. And I know you're leading our Ghana chapter, and you join our webinars on a weekly basis and on Zoom. So thank you so much for also continuing the mission of education during this time. And I hope the stigma goes away. It's unfortunate that, COVID-19 has to be associated with stigma when it's completely out of your hands. Thank you so much. All right.
Thank you.
Thank you. Our next panelist is Professor N. Mohammed. Professor Mohammed is the head of radiology at University of Witwatersrand in South Africa. Dr. Mohammed, you can share your slides when you're ready to talk about the COVID-19 measures in South Africa at your hospital.
Thank you for the invitation. I'm just going to share my screen.
Sure. And thank you, Dr. Rosen, for answering the question in the Q&A box.
Are you able to see my screen?
No, not yet.
Okay.
Thank you, Bill, and thank you, Dr. Rosen, for answering the questions in the Q&A box. The other panelists can also answer the question in the Q&A box.
Okay, I'm just having a bit of difficulty. Here we go.
Yes.
Can you see my screen?
I think it will take us a few seconds.
Okay.
Yes, now we can see it.
Thank you. I would like to thank the Health for the World for this invitation. And I'm going to describe the South African COVID experience. So today, the WHO reported a record increase in global coronavirus cases, with a total rising by 183,020 cases in 24 hours. And the global death rate currently sits at 471,204. So the results in South Africa, as of 20th of June, we had 92,681 confirmed cases. As you can see, the upward trajectory, and 40,478 who had recovered, and our death rate was sitting at 1,877. So South Africa is made up of 9 provinces, and really Western Cape, Gauteng, and the Eastern Cape have been the provinces that have actually had the highest COVID rates, with Western Cape leading. At one point, Western Cape held 65% of the country's COVID cases. If you look at the deaths by age, you can see that in fact, the highest death rates are between the ages of 50 to 69. And the case fatality over the period of time now in June has actually increased. And even case distribution by age, you can see clustering between the ages of 35 and 59. And we attribute this to the median age of the South African population being 27.6 years. And this is really contrary to the literature in many European countries. So when we look at South Africa's trajectory compared to Africa as a continent, you can see there was a very sharp incline in March. And on the 26th of March, we went into a very strict level 5 lockdown. And with that, the curve sort of didn't hit a very steep trajectory, but it still continued to go up. And as of today, South Africa still stands as the country with the highest number of COVID cases, but the highest number of deaths are actually in Egypt, which is just below us. So how does South Africa really compare to the rest of the world? As you can see, we started off in March with this very steep incline, which was very similar to United States, Brazil, Russia, the United Kingdom. But from the lockdown, we actually saw the curve flattening, and then again the curve, and now what's worrying is that the curve is actually increasing. We attribute this sort of change in peak due to the lockdown in level 5, which is twofold: people staying at home, and secondly, people during the 2-week period post-lockdown, people were not actually being tested for the COVID test. In South Africa, our gold standard is the reverse transcriptase PCR. We're also looking at Gene Expert. Unfortunately, we don't have antibody detection validated. It's available in studies, but it's not being validated. So really, now that we're going on the steep uptake, the feeling is more that the lockdown was to prepare the country for the increase in COVID-19 cases, upscale our medical resources. And this is the Soccer World Cup, where the 2010 Soccer World Cup was held, and this is the NASDAQ Exhibition Center in Johannesburg, and this was converted into a 2,200 COVID isolation unit, and it has been opened a week ago. So COVID is a multi-system infection. I'm just going to look at chest infections. So if we look at our Lancet laboratories in respiratory infections from 2018, 2019, and 2020, you can see during the period of May 2020, there was a significant drop in influenza, rhinovirus, respiratory syncytial virus, adenovirus. And the question was, is this due to the lockdown and the isolation of patients, or the fact that the patients actually didn't present to the hospital in May because of the fear of COVID? We followed the RSNA consensus publication on standardized language for chest x-rays and CT, and recently we've looked at the WHO guide for COVID-19 imaging. So what we actually developed is Microsoft Teams, teleradiology, as well as Zoom, and WhatsApp groups where we would teach our registrars. And this is a classic example of COVID. The next example, very classic, with the ground glass appearance and the interlobular septal thickening due to the release of interleukin-6, giving you the crazy paving appearance with areas of dense consolidation, very typical for COVID-19 as described in the American and the European literature. However, in South Africa, we're not only seeing this typical pattern. If you look at, this was our patient 0 at our hospital. She was admitted, her initial test was COVID negative, and then the repeat PCR was COVID positive. She was presenting with shortness of breath, and she presented 3 times to the hospital. She was treated with oral antibiotics and discharged. And apparently she did well, but as you can see, this is not a classic COVID that we would speak of, and I would attribute that to the co-infections that we see in South Africa. Coming to COVID in the pediatric population, as we know, strep pneumonia and Haemophilus influenza is the highest infectious cause of a disease in children under 5, and it's usually affecting Africa and Asia. So we published a WHO white paper in Pediatric Radiology on the interpretation of chest x-rays, taking into account that the experiences we see in the African and Asian continent. And then we also went on to look at artificial intelligence, and we published that in Pediatric Radiology as well in January this year. And then we published in Lancet, PERCH study, pneumonia etiology research in child health in 7 countries in the world. And as you can see by our graphs, bacteria, strep pneumonia and Haemophilus influenza were the major contributors in all 7 countries for bacterial pneumonia. And when we looked at multiplex PCR of 33 organisms, bacteria, virus, and fungi, we found very much the same picture. But so the question is, how will COVID impact this? So when I looked at the literature in US and Canada, they described COVID being very rare in children, and children usually do very well. And the question to us is, will this be the case in Africa and Asia? So this, my colleague contributed to me. It's a patient, a 2-month-old, presenting with severe respiratory distress. The COVID PCR was positive, and the X-ray is rotated, as you can see, but there is this diffuse reticular pattern. The literature described the ground glass and the consolidation as signs of COVID, but recently, latest literature described bronchial wall thickening and reticular pattern in children. So I think we need to be aware of that, the imaging findings in children won't necessarily follow the adult patterns. And in addition to this, with the lockdown, we saw very few patients. And now post lockdown in level 3, we're actually seeing patients with advanced TB, that's the gone focus, and the highlight adenopathy with the donut sign, patient with highlight adenopathy and dense consolidation, both TB. And then non-accidental injury has increased significantly. This is an example we just saw a week ago, metaphyseal corner injuries, and these are very specific and sensitive for non-accidental injury, and the rates have really gone up. So the lessons that I've learned as a radiologist working in Africa and South Africa is that South Africa is on an upward trajectory. It's not a plateau. And the reason for this is that the economic sustainability which caused the easing of the lockdown. However, the problem is we are currently in winter, which June to August, and the latest weather report saying that we are experiencing the coldest winter in a decade. And this may be related to the global cooling effect. South Africa also has a high prevalence of both HIV and TB. And during the lockdown period, we weren't really seeing patients with complications. And now post-lockdown, we are seeing them. Respiratory syncytial virus, respiratory viruses and bacteria have now also increased in June. So the one lesson, COVID-19 infections may be mixed, hence we may see atypical chest imaging findings on chest X-ray and CT, and then we need to be aware of non-accidental injury and domestic violence, which has really increased exponentially in South Africa. And these are just some pictures from beautiful South Africa, snow in the Western Cape. Thank you.
Thank you, Professor Mohammed, for the excellent presentation. It's sad that the cases are rising due to the winter there, but it seems you have done an excellent job coping there. Also, the non-accidental trauma was news to me. I did not know that it's rising during this time, and that's unfortunate. Thank you so much for the great presentation. We really appreciate this. Very nice. Next, we have Dr. Ashu Bhalla. Dr. Bhalla is a professor at All India Institute of Medical Sciences in New Delhi, India, and is also the president of Society of Chest Imaging and Interventions. Professor Bhalla, you can start whenever you're ready. And thank you to all the panelists for answering the questions so well in the Q&A box. It is very impressive. Dr. Bhalla, can you hear us okay? I think we just lost Dr. Bhalla. Until then, I think we have answered all the questions in the Q&A box. If there are any more questions, you can submit it in the Q&A box and we can discuss. There were two questions which were submitted before the panel, and I would ask the question right now. Number one, the question was about teleradiology. Given the challenges of COVID-19, what has been the experience with teleradiology at your institutions? Were you able to, I think Max, you talked about it, you know, the remote PAC stations so people can read from home. But I just wanted to open up the question for everyone to see how has that been adopted at your institutions? Professor Mahmood, is there teleradiology at your hospital?
Okay, so I'm unmuted. So unfortunately, we do not have a teleradiology where we can report from home, but we've got teleradiology between Rahima Musa and Nelson Mandela Hospital. One is a pediatric and mother and child, and the other one is an adult hospital. So we're able to use that, which definitely is valuable. And Nelson Mandela Children's Hospital, where I'm an honorary professor, we have via GE centricity a teleradiology. So I'm able to view the cases offsite using the teleradiology. And I think it's just related to the finance of providing teleradiology. My colleagues in private, because we work in a government public sector, they all have access to teleradiology in the private sector in Gauteng.
Okay, that's good to know. And Dr. Max Rosen, you said there are home PAC stations which have been set up?
Yeah, so before COVID, all our neuroradiologists and all of our ED radiologists had home PACs for routine shifts after 5 p.m. And we've now ordered PAC stations, so everyone in the department, except the breast imagers and the interventionalists, if they want a home PACs, will have one. I think the challenge is once we get them is how to use them and make sure that we have enough people in the hospital every day to, go to conferences and teach the residents and be in the reading room. And, it's a little bit of a struggle because people say, well, during COVID, you said I could work from home. Now I can work. Now, I have my home PACs. What do I need to come to work for? And so I think it's going to be a little bit of a difficult period reaching a nice balance between having enough people in the hospital and also allowing people to be home feeling safe and having the hospital be less congested.
Right.
That's going to be a challenge for us.
Yeah, I agree. Dr. Bhala, I think we
Yeah, I think I got lost for a moment, no?
Yeah, no worries. Do you want to present?
Yeah, the Wi-Fi went off and...
It's late in
okay.
India right now, I know, so.
All right, am I on?
Yes.
Yeah, so I'm just, good evening, everybody. And I'm just going to try and emphasize what is different for us and what is similar is actually very similar for a lot of us. This is the hospital that I work at and where in the residential campus where Bhavya grew up. So what happens is that healthcare in India is completely divided into two kinds of hospitals, those which are entirely funded by the government or the public health hospitals, and those which are private, which with the private would have about 20% beds reserved for the poor, but they do not receive any funding from the government apart from the land initially. So mine is a university hospital, a teaching hospital, tertiary care, and this is the status in Delhi. I am not even talking about the numbers in India because I'll just show you the Delhi trajectory, which very much parallels. So we are still in the rising phase of the pandemic. On 22nd of March, we had one of the most strictest lockdowns, which went on for about 3+3, that is 6 weeks, after which we started to unlock. And what everybody feels is that it gave us time to prepare, but it delayed our peak. It also means that this is going to be a very long battle for us. So the epidemiologists and their mathematical models go on changing, and somebody said we may peak in July, and two people saying we may peak in September. We are wondering, we are fourth in the world now, are we really going to land up with gold medal or silver? We hope we don't displace US from the top. At least let us be second in this. We don't want the gold medal.
Dr. Bhala, sorry to interrupt you. The slides are not moving, so you might have to, now
I'm still on this slide.
Okay, sure. Now I get. Thank you.
Yeah, so in terms of Delhi today has 24,000 active cases, of which about 13,000 are in home isolation and rest are either in hospitals or so we have 3 levels of care. There are people who are poor and cannot be home isolated because they don't have a separate room to stay in. So they are taken into government quarantine centers. We are still not overwhelmed in terms of beds and testing facilities, but we are preparing for a larger surge, and like elsewhere in the world, huge temporary facilities are being created. This is how the Delhi trajectory is moving, and this is pretty much how the trajectory for India still is rising, rising, and rising. The only thing the government wants us to focus on is the deceased. What we have managed to keep flat during this entire story has been the mortality. And our focus is also to keep the mortality low. If we try to keep the numbers low, people will not test, or people will not come out to get tested. So we don't want that to happen. We are happy we are not panicking with so much with the numbers. And let me just show you how, this plays out. This is a kind of health bulletin which used to come out every day. Now it doesn't give details of all the hospitals, but this is our hospital. Yeah, so till about a couple of weeks back, we had taken in 702 patients into our facilities. And these are RT-PCR proven patients. Yeah, we have another 100 suspects who are temporarily held in the isolation ward before they are moved to COVID or non-COVID areas. So at any one time, we are holding about 800 patients. Now, how we have managed to cope this is that we had a trauma center, which was different. We have a burns and plastic center. And a few kilometers away, we had a newly built National Cancer Institute, which was to have about 1,500 beds. Currently, we converted all these into COVID facilities. Yeah, and we did not touch our main hospital, and we converted now this trauma center is like just 500 yards from our main hospital. It has everything. It has wards, ICUs, it has a complete diagnostic and IR setup. But what happens is that this wing is not running the ER. The main hospital is running the ER. So we do have, a lot of walk-ins of SARI through the ER. And for them, we handle in the main ER. And how we do it is that there is screening outside, which divides them into COVID suspect and non-suspect. And then patient undergoes a CBNAT or a chest radiograph. I would like to just emphasize how the government has evolved the testing strategy. We started with RT-PCR, and the first month was very difficult because we didn't have enough molecular diagnostics. Then, you know, world over, you may have seen the crisis we were facing with migrant workers who wanted to move from big cities into the villages, and the villages did not have molecular diagnostics, but we had a very robust tuberculosis control program, which was already in place across the country. So all our TrueNat, CBNAT facilities were converted to test for COVID also. So similarly, while our virologists had been working till then, our mycobacterium lab also came into the picture and brought the CBNAT facility into the ER. So our waiting time in the ER went down, and at least those with high viral load or whatever, 50–60% of the positives get caught at the ER itself. So we do a chest radiograph because we have two equipment there, which we divide into suspect and non-suspect. The two wings are separate, and those which fall into the suspect category after the CBNAT or CXR move to our isolation wing or to the COVID facility. 25% of our radiologists have been taken away on clinical duties. They have been retrained to work as doctors. So our residents have been taken away into COVID facilities. That applies to the faculty also. The junior and mid-level faculty have to work in the wards in the COVID wing. So they said they have even taken anatomy and physiology and microbiology, apart from microbiology, actually, everybody away. They tell you that whatever you can do, you do, and they tell, you know, you do the management part of the ward. All leaves, resignation, term ending, etc. has been canceled for the last 3 months. And all our OPD services are closed for the moment, but we run a, all OPD is being run tele. So every day we give appointments, and residents of all clinical departments as well as faculty sits in their respective areas, and we are giving teleconsultation, including prescription. Those who need to come in to the hospital are asked to come in through the ER. Our imaging strategy, you know, I'm very pleased to see a letter to the editor in the current issue of AJR from Italy, which at least talks about chest radiographs. Otherwise, it was, you know, everything was CT, with a lot of literature coming out of China and the initial Wuhan experience. In the public health hospitals, our strategy has focused on chest radiographs, yeah, because we do those in the ER, we do those on the bedside. Ultrasound units are also placed in all the wards and ICUs, which was there from beforehand. And as usual, the intensivists use it to do their point of care ultrasounds, and we use CT scans only for specific situations. You know, we are a little different in that majority of our work cannot be worked from home. So we can report from home, and we have a remote PAC station. But in India, the ultrasounds are not done by the sonologists. We do our ultrasound. In fact, your skill at ultrasound and ultrasound guided intervention, you know, places you like at a notch above. So also our IR department is not separate. So ultrasound and bedside IR in the ER as well as in the wards in the ICUs is a very big load for us. Like we are doing all drainages, even PTBD, everything for COVID positive patients, for COVID negative patients. So a certain number of us always have to be in the hospital. But we are on rotation, and we do this in batches. All of us are kind of practicing a universal precaution. So everybody who is dealing with the patient in some level of PPE, our teaching is completely shifted to online and is held at 6 p.m. every day, so that even for those for whom it is a working shift can join in. Yes, our healthcare workers, even in radiology, have taken a hit. That's about 6 radiographers from the casualty, our ER who tested positive, and a couple of our residents. But what we figured is that it was not because of you know, poor infection control practices. We figured that everybody wears a level 2 PPE, but then after doffing sits down and has their kappa and their dinner together without any masks. So even if one person gets infected, the entire friend circle was getting infected. So yes, we have had to take a hit. and healthcare workers have turned positive, but they are all doing well. Since our whole focus is on chest radiographs, we've kind of, developed these 7 radiographic patterns. We try to familiarize everybody with these patterns so that the moment they see them, they recognize COVID from non-COVID pattern, and a substantial number will remain indeterminate, but everybody knows the typical patterns. So we work on this 7 pattern approach, and we have gone into a lot of dividing indications for CT, because there's a lot of kind of testing. Means we have RT-PCR, we have CB-NAT, and for the last 3 days, we have huge numbers, about 16 to 20,000 antigen tests, which are being done in the community in Delhi. So we have tried to make a lot of permutations and combinations, but basically, we want to keep CT for the CT-PCR negative symptomatic people, as well as for complicated situations in proven cases, in which we feel, in fact, that if we are going to bring the patient down from the wards or the ICUs, it may be a better idea to do a CTPA at the outset and not to HRCTs, because we usually bring them down for unexplained deterioration, which cannot be sorted out on radiographs with a combination of bedside focus. So thank you very much. Existential questions, if somebody knows when will the pandemic end, and I hope I was audible and visible. Thank you very much.
Thank you, Dr. Bhalla, for the excellent talk and the important insights which you have from All India Institute of Medical Sciences. There's a question from Rose Naibanda. How many healthcare workers are affected at All India Institute of Medical Sciences with COVID?
So, we've been spread out across departments. I would say we are about 100 plus, but most of those were people who were not even coming into the hospital. So several of them, actually, the majority have acquired the infection in the community. We have not lost a single healthcare worker. Nobody has gone into a moderate or severe disease. Most of them, about 60–70%, have either recovered and gone home or in home isolation. We have lost a couple of our, not a couple, I would say about 5 of our retired, faculty or workers, but those all above the age of 65, we have not lost any, or nobody has turned serious amongst our current healthcare workers. Yeah, but the number would be about 100 plus, and it's across, starting right from sanitation workers to faculty, and particularly sanitation workers, because they tend to be living in very crowded tenements. And, in fact, when they acquire from the community, what we are worried is the spread to patients, like we do have a lot of geriatric and oncology patients who are still admitted with us.
Right. Thank you so much. I'll just finish this webinar because I know we are running above time. So Dr. Bhalla, if you can stop share, I can quickly share my screen for a minute. I think most of the questions have been answered. So let me just go here and do a slideshow. And thank you everyone for joining today. For the excellent and all the excellent panelists who gave such amazing talks. From Health for the World, during this time, we have a COVID-19 education center in radiology and also in other medical specialties, which you are welcome to check out. It deals with all aspects of COVID-19, including pathophysiology, infectious disease management, imaging, and there's a YouTube channel which you can subscribe to get updates. We also have an Academy website. We have a Masks for the World initiative to help with PPE needs in different countries, which is also on the website. These are some pictures from the Masks for the World initiative. There are letters for hope for people in nursing homes, hospices, and children's hospital who are fighting social isolation during COVID-19. And here are some pictures which have been sent from messages from different parts of the world, not just US, to nursing homes and hospices during this time. There's a physician support line for people on frontline. This is mostly in US, who are dealing with trauma related to COVID-19. And I think we've already answered the question and answers. And if you have any more question and answers, you can contact us at contact@healthfortheworld.org. And I would like to end with 2 quotations. This is from the Dalai Lama. Be kind whenever possible. It is always possible, especially during these times. It's extremely important. And another one from Viktor Frankl. We don't get to choose our difficulties, but we do have the freedom to select our responses. So let's choose to do good together during this time, as we are like a large global family. Thank you so much to everyone for joining today, all the panelists for their excellent talks, which were just amazing, and the lessons which we learned from each other were really spectacular. And thank you to the organizers and also to Dr. Bill Dillon, who could join today. All right, everyone have a great day, and thanks again. Take care.
Thank you. Take care.
Thank you. Take care, everybody.
Thank you. Bye-bye.